Welcome to the Athlete's First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals. Welcome to episode 12 of the Athlete's First Performance Podcast and part 2 of our pain series. So today, Josh is going to be explaining the drivers of persistent pain. So Josh, I'll let you take it away.
Yeah, so just kind of building off of what we talked about in part 1 as far as the physiology of pain goes. Now that we understand that piece of it, it's helpful to understand the different drivers that could be causing the pain to last with chronic pain or central sensitization or persistent pain. And the big questions or the big reasons why these are important is you're going to have or see patients that maybe day to day are going to have discrepancies in pain despite any sort of physical change. Or you may see two patients that have the relatively same injury, but they have completely different functions or completely different pain responses. Or you might see that sometimes one person may have a total knee replacement and somebody else may have a total knee replacement, and one breezes right through rehab and the other one takes quite a bit longer and struggles quite a bit more. So we'll just be talking about the different things that could cause that. Now, it's not going to apply to every single person, but they will apply in some regard if you are seeing different outcomes with patients. And the good thing is that, and the way I kind of look at it is that because there's so many different factors that can drive pain or make pain worse or make pain better, you have a lot of different opportunities to create change. So I do describe that to patients is that there's multiple things that could be going on. The good thing is that there's a lot of different levers we can pull to help make a change. So it can be overwhelming, but if you break it down piece by piece, it typically can be quite helpful and help the patient and you understand. So at this point, it should be clear that pain does not correlate with damage. Nor does it correlate with any one thing in particular, particularly regarding to the things that we're about to talk about. But if you have someone with persistent pain, you may be confused in that it might not even be the original structure that was injured that's causing the pain. The different drivers are going to be in that biopsychosocial realm. And the best way to describe this, I guess you could say, is to use the cup analogy. And that's something I got from Greg Lehman. Essentially, if we picture everybody having a cup, and if that cup were to overflow, that's when pain would happen. You have to think of it as that there's the different drivers that cause pain would all go into that cup. So that could be poor sleep. It could be mental health. It could be fear of movement. It could be different emotions, whether it's frustration or anger. It could be worry. It could be, feeling depressed or anxious or having social isolation, past experiences, and then physical stress. So if all those things are going into the cup, if something such as, a sprained ankle occurs, it could cause the cup to overflow and then to have pain. We'll go through each little category of drivers of pain, and then we'll talk about how some people's cup may be more full than others or why that may happen, which could cause them to have a pain exacerbation easier versus someone who maybe his cup isn't that full. So if we start with the bio side of things, we can look at starting off with the obvious to be your physical stress. So I kind of like to think of it as if you are, let's say you have low back pain and you have to sit all day and sitting hurts, that would be physical stress. So the more you're sitting, the more you're filling up your cup. And you can think of a way to treat that as the more you move or encourage changing different postures or stand or walk or sit up straight versus slouch, that variety of movement could possibly decrease what you have in the cup in regards to physical stress. And that can be extrapolated to any other injury. So physical stress is one. Another bio side of things could be comorbidities, particularly one of the comorbidities that is relatively correlated with chronic pain is cardiovascular disease and pulmonary disease. So just any sort of, I mean, obesity, any of those things could create your cup to fill up more, I guess you could say. Some other things more into the psycho side of things are going to be in general stress. And you can think of that as stress related to work. So if someone has a job that they feel like they have poor control over, or has high expectations of returning to work that they don't feel like they can meet, if they feel like they lack work autonomy, or they're not able to modify their work, or just general poor job satisfaction, those things can go into that cup and help fill it up to the point where it may overflow. You can also look into the like depression or anxiety, and those things can stem from worry or social isolation, and those things can also create fear of movement, and that can create stress. So there's a lot of different things in the mental side that I think is probably becoming more prominent now. And I think that those things also can play a role in what sort of fills up the cup. Does that make sense, James?
Yeah, definitely. So I have a question for you. How are you picking that up? Are you doing that through your intake form, or are you just kind of getting an understanding of where they're coming from with this objective, or are you just straight up asking them? How do you get that information?
Information in regards to
To
basically all these factors.
yeah, different stressors that we use for explaining.
Yeah, I list. Oh, I mean, you can. I mean, if it's a work related injury, you probably all know that in the referral. But yeah, just listen to them. You can kind of get a sense of where they're at. I do like. I don't know if this is really tied to anything, but I try to pay attention a lot to even just how they like come in, how they sit in the chair, how they, if are they sitting there bouncing their leg up and down. This may not mean much, but I've seen a few patients that have their nails like chewed down to like nothing, So I'm like, is that a nervous tick? Is there anxiety there? Is there depression there? Obviously, you can look at their their medical intake that they filled out. But sometimes you'll see depression listed, but it doesn't necessarily like show up to where it may not affect anything. But yeah, I just look at, I just kind of watch them and see what they do as far as just, I guess, the way they approach interaction with me. And then I'll ask a lot of questions, particularly I like to always ask is like, have they had care before? Have someone else seen them for this injury? Are they direct access? And then I always ask them like, what did they tell you? Because I don't want to, it helps my education. So I don't want to throw a bunch of stuff at them. I like to know what they know first, and I can decide if that needs to be steered a different direction or not. So yeah, it's a lot of questioning. I know there are a lot of intake forms that you can do. I know for back pain, the Start Back tool is really good. It kind of looks at the whole biopsychosocial thing. So that I've used that before too, but I think just taking a good history and listening is probably what I use the most.
Yeah, I agree. And you can definitely tell a lot about a person just by the way they carry themselves and their body language and things like that. So just being able to pick up on those subtle cues will give you a good information in terms of how they're thinking and where they're at physically and mentally at that point.
Yeah, I think that, yeah, body language is super helpful. You can't read into all this stuff too much. You just got to kind of take what comes at you and then sort of paint a picture. But yeah, I mean, if we'll go through each of these, so I mean, let's start with sleep. That's my favorite one anyway. So with all of these things, and we talked about sensitization, if there is a lack of or too much of, depending on the category, it can increase your sensitivity to having pain, or it can increase the sensitivity of that alarm system, that danger system that we talked about last time. So sleep is going to be more of a protective factor. So getting the right amount of sleep. And that's something that I do ask James is like, how much are you sleeping at night? And some people, I feel like they may not correlate it with what they're feeling, but at the same point, they always say, if they're not sleeping well, they always like know that that's a problem. I don't know. Have you noticed that? Like if you ask somebody, hey, how much you sleeping? If they say, oh, I'm sleeping, 8 hours a night or whatever, great. But then if they say, oh, I don't get enough sleep, like they know that's an issue.
Mm-hmm. Yeah. And a lot of times they'll just tell me I can't sleep because I'm dealing with this or that. usually pain or just
Right.
fear or worry. So that's one of the biggest things that they say is in terms of their goals. I want my pain to decrease so I can sleep better or not wake up as many times throughout the night because I'm in pain. So a lot of
Right.
people do understand that and want to be able to get better sleep because they just feel better and they know all the important factors that go along with sleep.
Right. So, and I think that, and that's important, obviously. But one of the other thing I will ask is, like, if they say I'm not sleeping well, I'll ask, is that pain related? And they'll either say yes, or they'll say no, I've never slept well. Or if they don't say that, I'll ask, like, is this how you've always been sleeping, or this just happened once you got hurt? Like, is pain waking you up? Because if we talk about that cup analogy, if someone has just like a chronic, like poor sleep hygiene, you can go ahead and assume that cup is filled up more than probably it would be if they were sleeping right, which is just going to increase sensitivity. So I think the fuller the cup, the more sensitive you are. Um, so yeah, sleep is protective. So if you can get a good amount of sleep, maybe pour a little bit out of that cup. One of the ways I like to, I try to educate them on the purpose of it, but I ask them if they're open to being educated on it. And I also don't necessarily approach this day one. But there's a book called Why We Sleep by Matthew Walker. And it's a really good book, but he has, I think it's 10 or 12 tips. It's like a little printout where he talks about like the different things you should do to help improve your sleep. And this might be a good topic for a different podcast, but the number one thing I always say is just like start by waking up at the same time or going to bed at the same time. You can pick one, like whatever's easier for you. Just do it go to bed at the same time every night for a week. I'll tell people, even if you can't physically go to sleep, attempt to lay down. If you can't, then you can go out onto the couch, read a book, but don't watch any screens. Just try to get a routine. And that, I feel like, is half the battle, because a lot of these people will be up, especially the elderly, so like 4 a.m. And sleep affects a lot of different things besides pain. So that's one of the first things, but there's a lot of other things as far as temperature of the room and how you should wind down and stuff like that. But we can talk about that on a different day. But yeah, if you could look, I think you could Google those tips, like 10 sleep tips by Matthew Walker, 12 sleep tips or something like that. So I really like that. I really like working on sleep. It seems to be easy. Most people know what it feels like to have a good night's sleep. So it's kind of easy to educate them why it's important. So if we move now down, I'm just going to go down my list into more mental health. I will sort of throw anxiety, depression, and catastrophizing beliefs under that category. From what I was reading, they could consider these bi-directional factors. So they could be there prior to the injury, which maybe helped create, depending on the state of the injury, or they could obviously occur after the injury, depending on how it affected their lives. But it sort of puts people in a little bit of a vicious circle in regards to their pain and function. And in general, those things will increase the sensitivity of the nervous system, and particularly anxiety and depression, which are talked about a lot. That's something that, if it is noted to be a problem, it isn't a bad idea to have some sort of psych professional in your kind of ring of referral network, I guess, because working on those things could be more important than doing the typical PT things. But can be helpful to try to figure out maybe why they're happening and see if you can sort of steer them in the right direction. The next one would be fear of movement. And I think we've all seen this. Anytime someone has pain, they're going to avoid having pain. The hard part, which is fine and purposeful in the beginning, but the other time you might see this is when they've been told by someone previous, a family member, friend, healthcare professional, that they shouldn't do X, Y, and Z because it'll hurt them. So you're going to approach those in two different ways, but both those things cause fear of movement. And if we talk about the alarm system being your pain system, if there's fear, it's going to crank that alarm system up, and it's going to be hyper vigilant of any sort of nociceptive input that it might get. So it's not going to be, it'll go straight up, it won't be down regulated. So the best way I would treat that as with graded exposure, which is pretty much how my foundation in treating everything, but just gradually exposing them to the movement that they might find to be scary. And if there are those false beliefs about, well, I was told I shouldn't squat with my knees going over my toes, or I was told I shouldn't bend forward with a flex spine, or I was told I shouldn't slouch, you'll probably have to gradually change their beliefs on that. But first, by understanding why they had the belief, instead of jumping right in and saying, oh, well, that's okay to do. And then you can gradually expose them to the movement once they're comfortable with it. So that's probably one of the more prominent ones you'll see with your patients. In general, I'll also classify, I guess we can call these emotions, but this is not an all-encompassing list, but in general, frustration, anger, and worry. So I'm sure I'm assuming if anyone's been hurt, they've been there themselves, where they're frustrated, or they can't do something, or they're angry because it's been there for a long time and nothing's really changed it. Or they're worried because there's been no answer for the issue. So all those things can increase sensitivity, possibly increase anxiousness or anxiety. Worry possibly could increase depression-like symptoms. So they all sort of funnel down into creating a more sensitive nervous system. One of the ways I like to go about that is, and I didn't do this when I was early on in PT, but I find it to be helpful if you just note that they're having these emotions, like, oh, you seem frustrated, what's going on? Oh, you seem angry, like, what's going on? And just get them to tell you why they may be feeling that. I think they like that you notice it, and you can really get a good idea of what is causing that issue and how you can maybe correct it. I think you can kind of treat those all the same. And the ways I like to do it is try to do things that are fun, I guess, or try to always encourage if they make a big gain, or like celebrate a win. And then also just making things as close to what their goal movements are as possible. So for example, I have a lady that had pain for a really long time. And her biggest goal is to kneel down on the floor and then be able to get back up. So we broke it down into pieces, and gradually she was able to get down and get back up. And it wasn't that she didn't have like the physical factors to do it, such as strength, flexibility, and balance and stuff to get up and down. She just, one, didn't know how, and two, was not confident that she could do it, or was worried that she could do it, or maybe had some fear about the movement. So as soon as we got her and broke down the movement and make sure she could accomplish each step, and then just had to run all the way through it, that was like a big accomplishment for her. Wasn't anything crazy. We did, for her, it was easy. We did it in a session. Some people it takes longer, but just trying to show them that, hey, you can go do these things. Like, someone really wants to go walk, it's like, all right, we'll go walk, and go walk for 5 minutes, 10 minutes, and we just gradually build up. So any of those type of emotions that are like frustration, anger, or worry, I would typically treat with like encouraging and celebrating improvements and things like that. One of the other ones that's tough to change on your end, outside of just being like a nice person, is social isolation. So you'll tend to see people that come in, possibly maybe they're elderly, maybe they're just more introverted. They just don't have a big social network around them. They have a lack of social interaction, and that can create some of those depressed type symptoms, just not in a good mental state because of it. So promoting self-efficacy, again, encouraging fun activities, trying to work on together ways that they can return to certain things, and just asking them like, hey, what's fun for you? What do you want to do? And why can't you do that right now? Can also always be helpful to sort of pull them out of their, I don't know, funk, I guess you could say. Just trying to encourage them and make them happy, essentially. Stress can come in a lot of different ways. We've already talked a little bit about physical stress. Mental stress was basically kind of what we just ran through. But if you think of it as an all-encompassing factor, you have to work on determining what is causing the stress. Is it home related? Is it work related? Is it just personal stress? And then sort of attack from those angles. So I think again, just asking like, hey, you seem stressed, what's going on? Because that can increase sensitivity and also sort of more chronic problems, which I'll talk about towards the end. Past experiences, that's a non-modifiable risk factor, but it is a risk factor that you can modify in the way that the patient thinks about it. So past experiences can be as simple as just previous treatment, previous injury, or their friend had the same injury, someone on their team had an ACL, they had an ACL repair. So you can't change the fact that they've experienced it, but you can change the way they look at it. But there could be even more serious, like stressful, traumatic events that may be out of our wheelhouse to work with, but you could always consult with a counselor of some sort if that is related to what's going on and possibly driving the pain or the dysfunction. So past experiences, typically non-modifiable, but if you can dive into what's going on, you can sort of steer them in the way that they approach that past experience, which may help them. And then employment, I guess, would be the last one. We've talked a little bit about job related things, but particularly those who are not employed or on disability, those people are more likely to have chronic pain. And then just the general poor job satisfaction can be something that drives that pain level. The hard part is with that category, some people just don't want to go back to the job that they were at. So it's hard maybe to differentiate between actual chronic pain or sort of the, what's the word for it? Malingerers. Yeah. So yeah, that's, I hope that was a lot, but essentially all those things can go into that cup and fill it up. Now, if you already, before you even, and I've thought about this before, and I don't know if it's, I don't know, just the way I think about this is that you could see someone come in and they went and bent over and picked something up off the floor and their back hurts now. But you look at them and before this, they had poor job satisfaction. They didn't have a great social life, I guess you could say. They weren't very active. They may have some comorbidities. They may have been diagnosed with some sort of depression or anxiety. Their cup is like already full. So if they do one thing, it could send them over the edge. And that's when you may start to see people with pain that seems more than what it would typically be for an injury that maybe that's like an average person would have. So I think keeping in mind that cup out analogy, like what goes into that cup and why maybe one day it's cold out and now they have pain, or they didn't sleep very well and now they have pain. So it's a good way to educate. And the biggest piece of that whole analogy is that we can get a bigger cup so that we don't have a finite size of cup. So we may not be able to change your employment status or your mental stress or things like that, but we can change the size of your cup, which could be like changing your robustness or changing your overall tolerance to activities or stressors in general. And one of the best ways I feel like as PTs we do that is education and exercise, whether that's in the form of particular like strength and conditioning principles or more in the form of just general movements that they want to get back to. So I really like that cup analogy. I've also used it as a circle, like everything's inside, all your factors are inside this circle. If it gets out of the circle, you're going to have pain, but you can always get a bigger circle. And that's how I sort of educate why we're doing certain exercises. That makes sense?
Yeah, that's awesome. That's definitely a lot of information, but I agree with all of it and it's great to hear it. How would you go about taking someone through like an exercise program? So say they're pushing back on you and they're having pain and they don't know how much they should push. Like, how do you educate them throughout that session? How do you take them through that?
So if it's someone who's super sensitive, I'll have them just move in ways that don't hurt, because I feel like continuing to bombard the system with pain, 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 and they're already like very sensitive or very afraid of it. Let's just move with no pain. Let's just show them that they can move without pain. May not be like the patient we were talking about earlier, before we started recording, the patient that you have with a foot injury. Like maybe just have them move, like just do some long arc quads or like do some hip work, like just having them move the leg in general. So yeah, if it's someone who's very sensitive, but I don't have people held in that category very long. If it's just kind of your general like mid-level pain when they do stuff, I just have them do things that I know are out of their capabilities. And I just ask them like, how did that feel? I don't say, did that hurt? Just like, how'd that feel? Where'd you feel that or whatever? And sometimes you have to really ask them to describe it. And then I'll say, okay, was that tolerable? Or is that too much? Just kind of give them the control, but it's super general. Like I'm not going to have a cutoff. I know sometimes with like the tendon, or tendinopathy research, it's like you have to have you should have a little bit of pain with it. But I'm not going to get into the numbers. I just ask if they can tolerate it or not, because I already know that physiologically they're capable of doing it.
Yeah, and that's what I was really getting at. Like if you have them like at a 3 out of 10, okay, that's good. But if you're at a 5 out of 10, we have to stop. So you're pretty much just giving them full control over what you're doing, giving them the options and let them choose if they're able to physically or mentally do it or not.
Yeah, I'll say like I'm never going to give you anything or ask you to do anything that is going to harm you. And you always have control to tell me that you don't want to do something. If I give you something and you're like, I don't want to do that, or I don't think I'm ready for that, then tell me. We should have a million different ways to accomplish the same task, or even just to accomplish a different task. Typically, like I said, with people with persistent pain, there's many different routes to go. So yeah, I just give them control, but it's guided control. Yeah. And I want to challenge their fears. Like I'm not going to have, if they're afraid to like bend over, picks them off the ground, I'm not going to have them pick up 50 pounds off the ground, but I may start with just if it's really like sensitive, just double kneaded chest and supine or seated, like, you know what I mean? So you can sort of break that movement down and just meet them where they're comfortable.
Yeah. What value do you see in just getting the heart rate up, getting them on a bike or a new step or whatever you have in the clinic, just get their heart rate up, get them sweating in a comfortable way? Do you ever just do that? Like a burner at the end of a session, just have them go what they can do?
I probably haven't done that at the end of a session. I guess you can think of it as like the warm up. I'm sure there's stuff out there that I just don't know it I don't know the physiology behind it, but I do know that, cardiovascular exercise is good for you. And most of the people that have chronic pain typically aren't moving enough. So yeah, I would put them on some sort of, and typically like a pain-free thing, like whether it's a bike or if they want to walk on the treadmill, something, and just have them go for 10 minutes, get their heart rate up. But yeah, you could push them, I would imagine, at whatever they're comfortable with. Like I said, if you can, if they want to do some like harder or more intense work on a rower or on a bike and they're comfortable, then yeah, by all means. There's nothing wrong with cardio. And most of the time, like I said, these people are probably not moving as much as they need to. So you can throw anybody on a cardio machine, they'll benefit.
Definitely. Anything else you can think of in terms of patient examples or things that you use often in the clinic?
As I said, I think we touched on the education stuff. The only other thing I would say is that, and I don't know how to really, I guess, verbalize this, but when you see someone come into the clinic and you can tell that they've had, their, whatever it is, we'll just say low back pain, since that's pretty common, and they've had it for a really long time. And you can hear them telling you, like you can hear it in their voice, you can hear them telling you that they can't do this anymore. They haven't been able to work. They're struggling financially. Their sleep is messed up. They're having issues with their like all these different things. And if you can sort of build that back to when the injury occurred, you almost can see, like you can almost see the person that they were or that they could be, and they're kind of a shell of themselves now. And it's because they've been in this spiral. So if you have a poor control of these stressors, it can affect your immune system. your endocrine system, your neurologic system. So like for immune system, you're basically in a pro-inflammatory state all the time. Um, Neurologically, you don't really have the ability to have those endogenous inhibitory factors that a typical normal functioning nervous system would have. And then endocrine would be a huge one, like fatigue, memory change, sleep disturbances, cognitive changes. So like you can almost see that person, and knowing that these factors affect pain, you should be able to identify like these things have happened most likely because of their pain. This is where they were, and this is where they are now. And, chipping away, trying to get them back to where they were. But I know persistent pain can be super confusing. A lot of people don't like to treat it, but it can be super rewarding if even and like this people are super appreciative. You just have to try to get an idea of what of these drivers beyond just the physical injury is causing the pain, and then just start chipping away. And one of the big things is just like be nice. If they trust you, they'll probably get better. But you have to make them trust you first. So yeah, it's complicated, but I think it's fun. It does. I mean, truthfully, like if you see this patient population over and over and over and over and over, that can drain you a little bit. But some of my favorite interactions have been this patient population.
Yeah, I know some people love it, some people not so much. Final question. Do you have a certain threshold for referral to like a mental health professional or a dietitian or someone in your network of people or professionals? Like if you're seeing someone and they're just not getting better, or you don't think what you're doing is what they need at this moment, what's your referral threshold?
So for like dietary changes, I pretended like I don't know anything. I mean, I know you eat fruits and vegetables, but like I don't know much about that. So yeah, if someone is having dietary issues, then yeah, straight to a dietitian. And it's good to have one. Where I work now, we have one on staff, so it's good to have somebody. But it can't just be like the dietitian that helps you lose weight. Like it has to be somebody that deals with that. So that could take some research, and it's probably few and far between. But I think more likely referring to some sort of psychology or psych professional would probably happen more often. And for that, it basically, I would do that when I feel like I can't control like the emotional state. So if the emotional state or the if I feel like we're in there in the session and it's just we can't really do a lot. I mean, talking to a patient for 30 minutes is perfectly fine at times, but if that is driving the plan of care more than anything else, I would say that's out of my wheelhouse at that point. I mean, I know we all kind of do some like mental health things while we're treating patients, as we should. But if that's what's driving everything, like you're not really even getting to the physical side of things, then there's better people to deal with that than me. And that's when it's great to have somebody in your network for that purpose.
Yeah, I agree. So my current position, we're going to be surrounded by mental health professionals, registered dietitians, sports psychologists. So in our setting, once we get everyone there, there's not going to be just one patient seeing one of us. When one patient comes into the clinic or where we are, they're going to be seeing a gamut of people. So they're going to be seeing the dietitian, they're going to be seeing PT, mental performance coaches. So I'm excited for that and get that experience. So I think it's going to be a really good opportunity for the people that we're working with just to get the full gamut of everyone working with them instead of just a single provider trying to hit all of these different things, because it definitely gets complicated.
Yeah, I mean, that's great for them, but I'm excited to see what you see as improvements, because I mean, that should be the way things go. Like that, I mean, particularly depends on we're talking high level athletes, we're talking people with chronic pain, like that should be the way that everything is treated, because nothing occurs in a silo. So I'm excited to see what you notice as far as progress and improvements go with everyone utilizing all of those disciplines at once.
Yeah, it'll be interesting. So by the end of the year, we should have a full team of people working with us. So be able to get you some updates by then.
There you go. There you go. I think that's all I got. Hopefully it wasn't too rambling, and hopefully it was helpful. But yeah, I think that'll do it for me. Do you have anything else to add?
No, I think Matthew Walker's book is definitely on my to-read list. So I'm super interested in sleep and performance gains that come with sleep. So I think that's something that's huge and a lot of people are missing at this point. So definitely going to be reading that. What do we have next in our series for pain? What are we talking about next week?
So the last thing that I wanted to do was just how to use pain education, I guess, or how to utilize the knowledge that a provider would have of pain and how it works with a patient. And I'll probably do that with the basis of a case study that I did with a patient, and then add things as we would need to. So we could just say how to do pain neuroeducation would be a good way to sum that up.
Okay, perfect. Get a real life case study and see how it works in real life.
Yeah.
Awesome. Awesome. So thanks everyone for listening to the Athletes First Performance podcast. Make sure to let us know if you have any questions. You can reach out to us on our website or social media, or just give us an email. So thanks everyone. See you next week.
See ya.
Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.